So sorry for that. So I'm going to talk about current state of Y90 for treatment of metastatic disease, and I'll try to talk faster than normal. And so I don't have any disclosures. My objectives are kind of to review some of the existing literature on Y90 for metastatic colorectal cancer. I really discuss the importance of patient selection, and then review role of Y90 in the treatment of liver metastasis, and then discuss a little bit about complications. So everybody's kind of alluded to the scope of the problem. So liver metastases are present in 20 to 35% of patients. And the majority of liver dominant lesion or patients with liver dominant disease are not suitable for resection. The survival of untreated liver metastasis is pretty poor. And we can convert patients to resection with chemo. They have about a 5%, they have 30 to 50% 5-year survival. So everybody's seen this graph, and this was the much celebrated trials for CERT as a first line setting with FOLFOX in SIRFLOX and Foxfire data. And obviously they did not meet any of their endpoints. Overall survival was pretty much the same. Even progression-free survival was the same. If you look at it kind of up close, you kind of start noticing that maybe there was some leaning towards or favoring CERT for progression-free survival. And when you looked at the SIRFLOX data, you saw that we were able to control liver lesions. It just did not translate into any of the other markers that they were using. And part of the problem was patient selection. And we can see that, these patients where this is the lonely liver lesion here versus this liver lesion versus these multiple liver lesions, you're going to have different outcomes. And so I think that's kind of the main point of this, is that, maybe Y90 is not a good treatment for initial or treatment with FOLFOX. One of the things that I think brought down or made it a negative study was that 45% of patients had their primary tumor in situ while getting Y90. And there's a study that showed that patients with intact primary had a 50% increased chance of death. A quarter of the patients randomized to CERT actually got CERT according to protocol. So that means 75% of patients, a quarter of patients did not get CERT according to protocol. 40% had extrahepatic disease, and there was a 7% crossover. So once this trial came out, people started looking at patient selection, and there's a good study from Dam et al. That looked at 106 refractory liver dominant patients and found that there are 3 factors that were accounting for decreased overall survival. So that was tumor load greater than 20%, CEA or CA19 level greater than those, and a performance status less than 80%. And so the median tumor load of this group was about 15, and you can see that if your scores were 0 or 1, your overall survival benefit was about 10 months versus 5 months if you had 2 or more of those factors. And so another study, this one out of Sloan Kettering, looked at stratifying outcomes based on a Cox regression to identify some of these other factors that affect it. And they found that number of extrahepatic disease sites, CA levels, albumin, ALT level, tumor differentiation level, and the sum of the 2 largest tumor diameters made a big difference. And what they did was they created this normogram. And what it was is that, let's say, if your size was 12, you would get about 25 to 30 points. So if everything else was, 0 points, then when you get down to the scale, your total points would come about here. And so overall survival for 1 year, you had a 90% chance of surviving 1 year. If you were 80 or more, then your chances of surviving 1 year was 10%. So overall, it was about 100 patients that were in this trial. The average time to treatment for Y90 was 30.9 months after initial diagnosis, and the overall survival for the cohort was 11.3%. So that kind of brings us to the topic of, so what exactly is the role of SIRT? And I think salvage and chemotherapy, there's tons of studies that show that it's effective. The overall survival is probably somewhere in that 10 to 12 months range. Like a lot of the interventional radiology studies, a lot of the stuff is prospective, single center studies. These are kind of the main ones that were prospective. These kind of were retrospective down here, and they all very similarly have this about anywhere between 8 to 12 months. And then there's they looked at Kennedy looked at these studies and said, when do I get the most bang for my buck with Y90? And so they looked at several of the studies, and you can see sort of the number of patients here, and you can see that as a second line, there's the best sort of survival is used as a second line. As fourth line, you're dropping down your median survival to about 8 months. And this was sort of just kind of another look at it. This was from a center that single center cohort of 226 patients with metastatic colorectal cancer. And they did a standard of care versus standard care plus Y90. And it showed that about 12-month overall survival for the patients that got SIRT, and only about 6.5 months survival for patients that did not get SIRT. Again, this was unresectable liver metastasis that received several lines of chemotherapy prior. The other thing that I think is interesting, if you look at the Surflox data, they did a subgroup analysis and found that Y90 could downstage unresectable patients or borderline resectable patients to resectable patients. And what this study did was they actually looked at they actually got a bunch of hepatobiliary surgeons into a setting, and they had them review scans blinded to one another, to treatment assignment, extrahepatic disease status, and basically they just got the images from at the time of presentation, and they defined resectable as 60% agreement. And what they found was that in the SIRT group, more of the patients were resectable than at baseline. And you can see that at baseline, they were pretty much equal. And specifically what happened is with this 25%, right, with hepatic burden less than 25%, about 50% of patients became resectable. As opposed to if you went to a hepatic burden greater than 25%, then there was no difference in resectability of these patients. So I think that's kind of one of these areas that we can add value is if you have patients that are potentially resectable, Y90 could give you some extra time to see what the tumor biology is, as well as control the disease within that lobe, etc. So one thing that's kind of been shown is that tumor location does predict survival. And it seems that left-sided tumors do better than right-sided tumors. And so people have looked at, or there have been studies looking at what happens when you do Y90 in left-sided versus right-sided tumors. And they have found that left-sided tumors do better with Y90 when compared to right-sided tumors. But one group looked at the Surflox data, and again was a subgroup analysis. And what they did was they looked at sidedness for the Surflox study, and they had, I think they had about 98 patients and 81 patients in each group, and they found that you got about 4.9 months improvement in survival when you treated right-sided patients with CERT plus chemotherapy, as opposed to when you did left-sided, there was no difference in survival. And that kind of sort of brings us to another topic, which is inadequate liver reserve for resection. And often, we have competing procedures, whether it's portal vein embolization or Y90. If you use Y90, the advantages are kind of you get the test of time. The treatment is also tumoricidal. And unlike portal vein embolization, it does not really induce growth of lesions or anything in the other lobe. The disadvantage is that it does take about 6 to 12 months to get adequate hypertrophy, as opposed to 5 to 6 weeks with portal vein embolization. And then kind of to think about future directions, I think will be based on genetics. This is a study from Janowski that looked at mutations in common things like BRAF and KRAS, and they found that patients that had no mutations obviously did the best. If you had mutations in any of those and you were moderately differentiated, you were sort of 8 months overall survival. And if you had mutations and were poorly differentiated, then your survival was pretty poor. There are a couple other studies that focused on the KRAS mutation and found that wild type KRAS were more radiosensitive to Y90 as opposed to the mutated KRAS. And so this was kind of some of the very recent investigations into this status. The problem is that a lot of these were retrospective. They had small sample sizes. The largest group, I think, was about 100 patients. The other two were 58 and 23, respectively. And so I think this is a kind of an interesting focus for future directions for Y90. And then briefly, just to kind of talk about side effects. In my practice, I've had very few causes of radiation-induced liver disease, mostly because we've kind of known that this is a problem from some of the neuroendocrine tumor embolization data. And there's really rarely that I'm not selecting the artery that's only supplying the tumors. And so I'm not really doing whole lobe liver injections if possible. I usually stage it, and I'll do it about 2 to 6 weeks apart if I have to treat right and left. So that's kind of my spiel.
That's great. Thank you. I guess I'm just going to pose two thoughts that pop into my mind, and then we'll go on to Dr. Kim's talk, which is one, I find this really interesting about this idea of trying to identify those tumors which are sensitive to the radiation. And just the random thought that pops in my mind is there something that we can do, think about in the combining of the two approaches from radiation therapy and Y90 to maybe test that and complement each other moving forward. And then the broader question, which I'll throw to the panelists later, coming back to it, is again, should we be doing more Y90?
I think me and Dr. Tao have talked about this before. The problem, I think, is getting insurance companies to pay for both of them. And I guess that's not always the objective, but the problem is that they'll deny one or the other if there's not a certain amount of time. And Dr. Tao can chime in more on her side of it. Is I think sometimes we're worried about overexposing some aspects of the liver with radiation, and so I think it's doable. I think it would require some next level dosimetry from our standpoint of defining exactly where all of the radiation has gone. And so, I think it's possible that there's these new things called voxel-based dosimetry, where you use a CT scan, and instead of using just either sort of the two-dimensional or one-dimensional. You actually use the entire volume to figure out how much of the radiation has actually gone into the space. So I think it's possible, and I think it's something that could be done. Is just the question is, how do we do it with the lowest amount of cost, et cetera.